Hello, everyone. Thank you so much for joining us. My name is Lexi, and I am part of the medical education team at Organon with a focus on medical devices, specifically the JADA system, which is why we are all here today. So good morning, good afternoon, good evening, depending on where you are in the world, because we do have many people joining us from around the world today, which is super exciting. We are here to focus on the JADA system and the clinical utilization during and after a cesarean section. And we also will be focusing on the team approach to placing the device. So here we can see our agenda and our learning objectives. So we are going to focus on the JADA design and indications for use. We will touch on some of the highlights of our clinical data focused around the use of the JADA system. We are going to hear about user experience with the JADA system, especially with patients who've had or are intra-op for a C-section. And then throughout the presentation, we will be focusing on best practices for adoption of the device and education of your staff. So I am so thrilled to introduce our two presenters for our webinar. We will be joined by Dr. Tori O'Daniel, who is from Mercy Hospital in Oklahoma City, Oklahoma. She's the medical director and OB hospitalist for the OB Hospitalist and Women's Services Group. And she's also the director of the OSU Medical Student Clinical Rotation. We are also joined by Dr. Karie LaFleur, who is joining us from Alexandria, Louisiana. She's an OB-GYN generalist, and she's also the director of obstetric emergency simulation training. So thank you both so much for joining us. I also do want you to let you know that this webinar is going to last about 1 hour long. Your microphones and your will be muted and your video will be turned off just to limit any distractions. And we definitely will have time for Q&A at the end of the program because this program will be recorded. So please utilize the Q&A box to input all your questions throughout the program, but just know we most likely won't be answering them until the end of the program. All right, I'm going to read this disclaimer really quickly for us before we get started. The JADA system is intended to provide control and treatment of abnormal postpartum uterine bleeding or hemorrhage when conservative management is warranted. For detailed information, including the indications for use, contraindications, and warnings, please consult the product's instructions for use. The information presented is solely for informational and educational purposes. This presentation is not intended to serve as medical advice because Organon does not provide medical advice. We are pleased to sponsor this program, and the program is not an accredited continuing medical education program, and it is not designed to meet any training and/or educational requirements. The speakers for this program are speaking on behalf of Organon, and they are being compensated by Organon for this presentation.
So first, we're just going to review some JADA basics. So the JADA system is an intrauterine vacuum-induced hemorrhage control system that's designed to offer rapid and definitive control of abnormal postpartum uterine bleeding or hemorrhage. So when we say abnormal postpartum uterine bleeding, we're talking about greater than 500 mLs after a vaginal delivery. So that time between 500 mLs when it's abnormal and 1,000 when it's considered a hemorrhage. And the JADA device can be used once abnormal uterine bleeding is identified in the postpartum period. Taking a look at the JADA device that's here on your screen. So you have at the distal end the intrauterine loop. It has vacuum pores, and those are covered with a protective shield. That's the portion of the device that sits in the lower uterine segment. Coming down the device, you have the expandable cervical seal. So that seal comes in the packaging with a little bit of air. The package comes with the syringe that's going to remove air from that seal prior to placement. And that is also the place where we're going to fill with sterile fluid to expand that cervical seal. You can then see the clear portion of the tube where you can see blood that is coming through the tube after placement. And at the end, you have your vacuum connector where the vacuum tubing that comes in the packaging, which is also going to be connected to your wall suction, is going to be connected there at that vacuum connector. And then the seal valve is the place where the 60 ml syringe that is a part of the system will be used to pull that air out or place that sterile fluid within the expandable cervical seal. So one study suggested that the JADA system could be considered as the next intervention for patients who are not responding to your first-line choice of uterotonics and uterine massage in the setting of abnormal bleeding or hemorrhage. And when we talk about control of bleeding that's rapid, when you look at the studies, which we will be discussing in a little bit, the median time for controlling bleeding after placement of device is 3 minutes. So it is something that does work rapidly. So now we're going to talk about patients who are appropriate, and we're going to move on to people that are contraindicated for use of the JADA device. So first, let's talk about those that are appropriate for use. So the device can be used during, as we said, that abnormal uterine bleeding phase where it's 500 to 1,000, or if it's progressed to a hemorrhage at 1,000 mLs or more. It can be used after a vaginal delivery or cesarean birth. It can be used in a multifetal or multiple gestation setting post-delivery, or in a person who's had multiple deliveries. It can be used in those instances where, for medical reasons, our pharmacologic uterotonics may be limited. So in the setting of something like preeclampsia, asthma, or hypertension, if there are fibroids in the uterus, that is appropriate for use as well. And with chorioamnionitis without a purulent infection. So when we talk about contraindications, we'll talk about, it's contraindicated with a purulent infection, but it's not contraindicated when we're talking about your typical intraamniotic infection like chorioamnionitis, things that are happening in the labor process. It is appropriate to use in someone who has VBAC'd previously, or maybe has just successfully completed a VBAC and delivered, or someone that maybe was toe lacking and perhaps didn't complete that toe lac all the way to a VBAC. It's also appropriate for anybody who may be declining blood products for various reasons, because of course it's not something that is involving blood products. So moving on to the contraindications, and I feel like these are pretty self-explanatory, but always good to review. So if you have an ongoing intrauterine pregnancy and have bleeding, this is not how we're going to control that bleeding. So if you have an intrauterine pregnancy, we're not using this device. If you have an untreated uterine rupture, so if the uterus ruptures and you have not treated it, you're not going to place this device for control of bleeding. However, once you have entered the abdomen and closed the rupture of the uterus and reestablish the anatomy of the uterus, then it's perfectly acceptable to use. If you have a setting of unresolved uterine inversion, so with the uterus inverted, of course, we can't place this device, but once you establish that anatomy, replace that uterus, then once that it's back in the abdomen, it's perfectly acceptable to place this device once it's corrected. We're not going to use the device with a known current cervical cancer or a known uterine anomaly. And in the setting of a purulent infection of the vagina, cervix, or uterus, we're not going to use this device. However, as I said previously, if you have a standard sort of chorioamnionitis type picture, that's very appropriate for use. And specifically for C-sections, which we're going to talk about a lot today, the cervix needs to be 3 centimeters dilated at minimum for use of the JADA device. And the reason being is if you see this cervical loop here, or this, this loop on the JADA device, when we compress this loop for placement, it's about 3 centimeters. So you have to have at least a 3 centimeter cervix to be able to pass this device into the uterus. Now we're going to talk about a category where there's some warnings and precautions. So this category, the safety of the JADA system hasn't been evaluated. So we don't have data on safety and efficacy in these patient populations. So if a uterus or a gestation is less than 34 weeks, or if you have multiples, the uterine size is less than 34 weeks in size, we don't have data on that situation. Placenta accreta and other placental disorders, we don't have data that says that this is safe and effective for use. If you have a situation where you have DIC, if you're in a coagulopathy, again, we don't specifically have the data that says this is safe and effective for use. And then also secondary postpartum hemorrhage. So in the first 24 hours after delivery, if you have a hemorrhage or abnormal postpartum bleeding that you want to control with the device that's acceptable and appropriate, after that first 24 hours, when you're moving past that, we don't have data that says that bleeding at that point treated with this system will be have the same response.
So now we're going to move on specifically to talk about the use of JADA following cesarean or C-section deliveries. Go ahead, next slide, Lexi, if you would. So we are going to ensure that our cervix is dilated to at least 3 centimeters prior to the use of JADA. And I know that Dr. LaFleur had mentioned that in her previous deck, which she listed sort of who's a candidate and who's also contraindicated to receive this device. So it's important, specifically when we're focusing on cesarean deliveries today, to understand who's an appropriate candidate. And your cervix has to be at least 3 centimeters prior to using that device. The other thing that's really important is to make sure that your hysterotomy is closed prior to using the JADA. Now, you don't have to close your laparotomy, so you actually can have somebody either break scrub and then stay scrubbed beneath or go beneath and place the JADA if you're working in an environment where there are 2 surgeons at the case. Or if you have to break scrub and place that while the laparotomy is open, you can kind of work with your facility to figure out how you are going to facilitate that. And we'll talk about that in just a few slides about how we've really tailored that specific workflow in our institutions. But your hysterotomy does in fact need to be closed because you're making this uterus contract with this device under vacuum pressure. So you want to make sure that the hysterotomy itself is closed. The next important or clinically relevant, which I think is super important to understand, is that you still can use this concomitantly with a B-Lynch compression suture. So in conjunction, having placed that, maybe you place the B-Lynch and then are still wanting to use the JADA, you certainly can do so while that B-Lynch is in place. Same kind of function that we'll talk about how you're using it in the OR. So during the JADA placement, either right before or in conjunction with you deciding to use the JADA, typically somebody is going to be consenting this patient. We encourage you to consent the patient about use of this device, and often it is the physician that will either lean over the drape, or if they've descrubbed and are getting ready to place the device, to kind of lean over and discuss what's happening, explaining them the need for the device that you are using and how it's going to work, and maybe some expectations briefly about what that looks like postpartum. And then at my facility, we also do another sort of recap or debriefing after the procedure is complete. When all of the excitement and hustle and bustle is done in the OR, we will go back to them in the PACU or their recovery room and then have a conversation about why we place that again, what that looks like for them postpartum, and what their expectations can be. We also, in some facilities, and this is how we work in my facility, is the nurses are really well versed. We do a lot of simulation and education in our facility to make sure that everybody, a part of the team, understands how this works. So in case they're participating in that, and also if they get asked by patients, that they're going to have knowledge to be able to explain what exactly the JADA system is doing. The next part of this is you do want to understand that you need to place this vaginally. So you're going to be placing it vaginally, whether you've had a C-section or a vaginal delivery, which makes sense. It's very intuitive with a vaginal delivery. But if you've used a different device where you could place this through the hysterotomy, this is not that device. This is a device that you need to place that through the vagina with that hysterotomy closed. You do not place it through the incision. The other thing that's really important is to understand that you should not be using excessive force when you're placing this JADA. So once you've learned how to place this, one of the things that I figured out really quickly is that I really do like my assisting hand inside the vagina to be able to place it. So I place my hand inside the vagina and then squeeze the elliptical portion with my left hand, and then I insert that into the vagina and pass it off to my right hand. And I can do that really smoothly. There's not any excessive force, and my hand sitting inside the vagina against the cervix allows me to sort of inch that elliptical loop into the lower uterine segment. And then I leave my assisting hand inside the vagina while my team has that sterile fluid that we're inflating into that cervical seal. And I usually leave my hand in there until about 60 cc's are in the balloon, so that I can make sure that that placement of the seal is where it needs to be. It needs to be extra cervical inside the vagina, creating that seal, and that loop then needs to be in the lower uterine segment. And you can assure all of that leaving your assisting hand in there. I always go straight to using 120 cc's. That's a preference of mine based on having used this for the past 2 years. So I let them insert that first 60 cc's, take my hand out once I know that it's appropriately placed in the vagina and outside of the cervix, and then they fill up the other 60 cc's of sterile fluid. The other thing that's important too is that you can place a grasper or like ring forceps on the anterior cervical lip if need to. You certainly don't have to place the device, but if you'd like to, you can. But you do not want to grasp the JADA with an instrument to help facilitate placement of it inside the uterus. You simply can use that with your hand. And again, I have found that doing so with my assisting hand really helps me a lot. And then the next slide talks about sort of how we implement this. What are the logistics of JADA in the OR? And it's a little bit different than when you're placing the instrument the device in the vaginal delivery room. So I think you're going to hear us say this probably more times than not, that we love simulation and education. And one of the reasons that I loved simulation and education from the beginning as a trainee is that I really liked how comfortable it made me in situations when everybody was very panicked. And this is not any different than that you want to make sure that everybody is confident and comfortable with the device that you're using, where it's located. So know where your JADA is before you need it. We do a lot of scavenger hunts at my facility so that people know what cart that it's in, what drawer that it's in, where is it located on the unit and floor, depending on wherever you're at. Understanding where the suction tubing is, where does that connect to? Are you connecting this to the suction device that you're using in the procedure? Are you connecting to a suction to the wall? Every facility is a little bit different. Making sure that you're not creating tripping hazards and things like that so that you understand. And it's not just the physician that needs to know how to do this. Everybody's a part of the care team. That comfort level with how this works is really where I feel like we started to smoothly use this procedure in our device in our ORs, because everybody was very comfortable with what it was doing, where it was at, how they played a part in that specific situation. And then handing off the JADA into the OR. So if you're handing off JADA from the OR into your recovery team, you're sort of thinking about what recovery room looks like and how do we transport. And we really quickly realized that we needed something to be able to keep the suction going as we transported these patients. And so we actually have portable suction devices very similar to what is on our crash carts, to be able to maintain suction, to be able to get them from the OR to our PACU. Have a PACU, but you do have a postpartum recovery room that they might be going to. Same thing. So we would take them with a portable suction and then connect them with a wall suction in their recovery room, wherever they're at. The last bit of information for us that I think was really important is to make sure that you know what the amount of suction you're supposed to be having. So depending on what you're using, whether it's wall suction or the suction device in your OR, you need to make sure that this is set at 80 millimeters of mercury, and that's plus or minus 10 millimeters of mercury. So you can up that to 90 if you don't feel like you have the appropriate contraction that you would like to be able to get that uterine contraction and appropriate blood control. But if your setting is different when you're using your suction during the procedure itself, you need to make sure that your team is very well versed in doing so. What about you, Dr. LaFleur? Are there any tips that you have in your OR?
Well, I second a lot of what you said, of course, and a lot of, to our nursing staff, our scrubs, our circulators, everybody being very confident about how this works in the OR. So of course, initially going in there, and everybody's OR set up differently. So each person's got to figure out, like you said, which canister are you using? If you're using, if you're using a wall regulator that's on the wall that maybe you're not typically using in a case for suction, but of course, now that you're thinking about, okay, is JADA going to be a part of our hemorrhage control in the OR, seeing if we need to add, you need to add a suction canister to that location, where specifically you're draping the tubing, because like you said, in so many ORs, we're passing, the traffic pattern passes back and forth. And so making sure that, whatever that option is, that it's going to be a safe location to have the tubing located. And then again, like you said, big on simulation, on training, on having those conversations where not only do we know where all of our supplies are, but the nurses have thought through, the whole system between where are we going to set this up? How are we going to position the patient specifically? Who's going to have those roles in maneuvering the patient? And then once the nursing staff and the scrubs and everybody have that system sort of mapped out for themselves, one of the biggest things that I think can impact the care of patients in this particular situation is confidence. So when the nursing staff has the confidence that they know how to implement this device, it then helps with the confidence of the provider. So as a staff, if you see a hemorrhage situation, and your provider may be asking for various medications, and y'all are communicating about the amount of blood that's lost, and you recognize that you're greater than 500, and you as a support staff member in that OR, is perfectly reasonable to say, do we want to get a JADA ready? Is this something that you're interested in? And if it is, then you competently and confidently, because you have arranged the system at your hospital so well that you know where to connect everything, how to find everything, where your sterile fluid is, and it's a very smooth system that really improves the confidence of a provider who maybe has only used it in a limited situation, or maybe is never placed in a C-section, because they know that you have the other half of this scenario very cleanly defined. So now it's just the placement portion that they're providing, because the team has everything so cleanly set up. And I think that that's been a huge shift at our facility as well, is the general confidence of the staff really, folds over into the confidence of the providers who are placing it.
Yeah, that has definitely been just really evident in my facility, is empowering those a part of our team to participate as a team. And I have appreciated it. I know when you're handling a crisis or an emergent situation, it's really nice to have people in the room that are helping walk through those steps with you if you are managing more things than one. And so that has anecdotally worked really well in my facility too.
All right, so the Pearl study, so this was the prospective single-armed multi-center treatment study that was sort of the pivotal first study for the JADA system. So you can see here there was 107 subjects over 12 sites in the United States, and the blood loss ranged from 500 mLs to 1500 mLs, but patients with the blood loss of 1500 mL or greater at the time of device insertion were excluded from the numbers of this study. The primary effectiveness endpoint was looking at the proportion of those patients that were successfully treated, and that means that they did not require any additional second-line interventions, surgical interventions, or had any loss of control of the bleeding once the system was placed and bleeding was controlled. The primary safety endpoint was the incidence, severity, and seriousness of those adverse events related to the JADA system. And you can see when we're talking about the efficacy of JADA, 96.7% of the devices placed had treatment success in the vaginal delivery cohort, and 80% of those devices placed in the C-section cohort had treatment success. And when the device is inserted, we are keeping that device on vacuum for a minimum of an hour, but some period of an hour or greater, depending on the provider preference and the scenario. And then we are deflating that cervical seal and removing that device from vacuum, but keeping it in place again for a minimum of 30 minutes for observation. But that 30-minute time is also extended based on the situation and provider preference. So in the Pearl study, the overall indwelling time, keeping both of those things in mind, was 3.2 hours. The safety profile of the JADA system, when we looked, we're looking at the safety overall, there were no adverse events judged as definitively related to the device or the procedure. And when you look, there's a very low rate of adverse events that were possibly related to the device or procedure. And those were things that are listed here, such as endometritis or a vaginal laceration repair that was made and then disrupted, or something such as bacterial vaginosis or candidiasis, which all of these things are possibly related because it's the patient population that we're inserting this device, or the fact that a device was inserted. All of those events were resolved with treatment. So again, no adverse events definitively related to the device or procedure.
So the Ruby study is the multi-center observational post-market registry. So this is after that Pearl study came out in 2020, and this is really looking at what people are using or what the results from the use in real time, right, in real life. So it was designed to let us see what exactly the results look like for patients or for facilities that are using this in a larger group. So this was 800 patients that were across 16 sites across the United States. And the cesarean group was 270 patients, and then the vaginal delivery group was 530 patients. And very similarly to the Pearl study, they wanted to look at the primary effectiveness endpoint as well as that primary safety endpoint. And the treatment success, as Dr. LaFleur mentioned, is defined as bleeding is controlled after the device is inserted, and you don't require treatment escalation, or bleeding did not reoccur after that initial bleeding of that was controlled after the device was removed. The primary safety endpoint was similar in looking at those serious adverse effects, adverse device effects, and then they've looked at that data that was collected from the time of the device insertion through the hospital discharge. So they really looked to see whether or not the device was causing any issues with the patient's safety. And the overall treatment success of the effectiveness of this device was, again, very similar and extremely successful in this cohort of 800 patients. So 490 out of the 530 in your vaginal cohort had a 92.5% success rate. And again, that was bleeding was controlled, no escalation of treatment. And in the cesarean trial or cohort, then there was 226 out of the 270 patients. That was 83.7% success rate. So a very successful treatment overall for both vaginal and C-section. And they wanted to make sure, just like they did in the Pearl study, that if you are using a device that is effective, we just want to make sure that it's safe and that we're not creating a bunch of adverse events for our patients. And there was 0%, so 0 out of that 800 that were collected had any incidents that were definitively related to this device itself. They did look at those possibly related incidences, and that was 1.1%, so 9 out of that 800 patient population. And then they separated that even further into the serious versus not so serious. And the serious consisted of 3 patients. 1 was hypotension and hemorrhagic shock, and then 2 were endometritis. The other not so serious that were possibly related were endometritis, fever, diarrhea, emesis, as well as abdominal pain. The last part of this analysis, which I love, this is what I really feel like kind of hit the head for me, is the additional outcome analysis that really looked at. And this was looking at treatment success in severe maternal morbidity. So if you look at both of these bar graphs, on your left side is vaginal births, on your right side is cesarean births, and the yellow bars are looking at treatment success. And you can see that that's inversely proportional to the amount of blood loss that you have. So the further or more blood loss that you get, the less the treatment success that you have. And that significantly drops down to that 40% range of treatment success when you have greater than or equal to 3 liters of blood. And I know that that seems like a lot of blood loss, but you and I both know, if you've been in the number of deliveries, how quickly you can lose blood in a delivery. And so I think it's important for everybody to recognize what that inversely proportional relationship looks like. And then the other thing I think that's super important is to look at whether or not you're increasing your need for blood transfusions. Greater than or equal to 4 units of red blood cells was in that sort of a salmon looking color, and then ICU admissions and hysterectomies, which obviously increase our risk for a long-term sequelae. So we're concerned about that, and that's inversely proportional. It's a very similar trend when you're looking at cesarean births. So when you have more than 3 liters of blood loss, your treatment success drops down to that just above 40%. So I love this slide. I think it really shows us what's happening in real time and how impactful this can be in your patient's life. So we're going to go on to clinical cases. Dr. LaFleur is going to start us off with her first clinical case report, and then I'll finish with mine, and then we'll have that roundup with some Q&A that we will answer live and wrap it up.
Very good. Well, my internet has been acting a little funny, so if at any point I lose you guys, we'll pop right back. I apologize. So this is a case where JADA was placed during a C-section. Of course, information in this case represents my personal clinical experience. This is a 27-year-old gravida 30020 who was at 39 weeks and 1 day's gestation. Her history was significant for having 2 prior missed ABs for which she had DNCs. And at both of these DNCs, she had significant hemorrhage So much so that I sent her to a hematologist for a workup after that second DNC with hemorrhage, and her workup was negative. She had no identifiable factors that increased her risk. But knowing her history and knowing that we were going to be delivering a baby, of course, our index of suspicion was very high that we would be up against another situation of abnormal bleeding. Her infant had suspected fetal macrosomia, and with much discussion and counseling, she requested a primary C-section. In prepping for the C-section, of course, we met as a team. We met with all of our staff that were working that day. We made sure that we were very ready. So we had our hemorrhage cart that's fully stocked, not only just outside of the OR doors where we typically have it, but in the OR and ready. We made sure that we had all of our pharmacologic uterotonics on standby. We made sure that we had our JADA system plus our sterile fluid and everything that would be needed to place that JADA physically present. We had blood present and ready in the OR, and we had a conversation with anesthesia that we planned to give an antifibrinolytic at the time of uterine incision. So she had her epidural anesthesia placed and underwent her primary cesarean section. That antifibrinolytic was given at uterine incision. Her infant was delivered, and the IV Pitocin that is standard was started. Baby was 9 pounds. And once the placenta was delivered, then at that point, uterine atony was noted and abnormal bleeding was noted. And so at that point, I gave her the Methergin IM and requested oxytocin IM on the surgical field, which I gave into the uterine muscle as we began closing that hysterotomy. As that hysterotomy was being closed, uterine atony persisted and a postpartum hemorrhage was identified at that time. At this point, we were communicating with the staff that, we were going to be moving forward. So start opening up the JADA system, start connecting and getting things ready, because that's the direction we were going as soon as that hysterotomy was closed. She was given a dose of Hemabate at that time as well. And I requested that she be transfused 1 unit of packed red cells that was available in the OR for transfusion. Once that hysterotomy was closed, then we placed a towel over the abdomen and proceeded to move the sterile drapes in the fashion that we have discussed with our scrub text in order to maintain a sterile field. And then that allowed us to then put the patient in a frog leg position and evaluate from below. Now, this particular patient, I can tell you, was 1 centimeter dilated prior to her C-section because she was really debating back and forth whether or not she wanted to proceed with this elective cesarean. And so we had checked her cervix prior to her case. At the time when I went from below to evaluate the cervix and the bleeding, she was still about 1 centimeter, but thinning out. And so as I manipulated the cervix to evacuate the clot material that was in the uterus, that cervix then became 3 centimeters to 4 centimeters dilated just with the manual manipulation with that clot evacuation. And at that point, then I placed the JADA device and noted that we were at 1900 mLs of blood loss at the time the device was placed. So the device was placed, connected to suction, and in 2 minutes, bleeding was controlled. So the first 2 minutes after the device was placed, there was this steady improvement in the overall uterine tone until the uterus was firm, and blood that was moving through the tubing initially was very brisk and then slowed down. I could see that it was slowing down. And at 2 minutes, there was 250 mLs in the canister itself. And I felt comfortable that things were controlled. Now, in this scenario, I was operating with a scrub assist, and so I did not have another physician. So once I felt comfortable that the bleeding was controlled, we repositioned the patient for surgery, and then I broke scrubbed and scrubbed back in to continue the case, abdominally. And so, of course, in this scenario, as I had said previously, I only closed the first layer of the hysterotomy so that anatomy, was closed so that we could then go below to place. So then I went after repositioning, the patient went back above, of course, and then, completed the surgery. And once the surgery was complete and we were coming out of the OR, our procedural QBL was 2,440 mLs. So the device was maintained on vacuum suction for 2.5 hours. Now, typically, an hour, of course, is the recommended or the requirement of time, but depending on the clinical scenario, that varies. We typically do an hour, but in someone who it's a little bit more challenging, sometimes we choose to add more time just so we sleep better at night, honestly. But this vacuum was discontinued at 2.5 hours. And then the device, when we discontinue the vacuum, we're also removing all of the fluid. And she had 120 mLs. As Dr. O'Daniel mentioned, we use 120 mLs in our cervical seals across the board. And so we pulled that 120 mLs out and left that device in place, taped to the leg for an additional hour of monitoring. 30 minutes, again, is the recommendation. In her scenario, we kept that in for an hour. And after that hour, her bleeding was stable and everything seemed to be continuing to be under control. So then the device itself was removed. So in this scenario, we had a 3.5 hour indwelling time for the device. And of a side note, when she left recovery, the QBL was an additional 150 mLs after being in recovery, and that was just from the time the device was on vacuum. So she had a 2590 ml blood loss total in this particular case. So this patient did great. I mean, she was discharged postpartum day 3. Her postpartum course was uncomplicated, other than the unit of Packard cells that was transfused intra-op. She didn't require any other blood products, no additional treatment beyond what was done in the OR and after her JADA placement. And then she was breastfeeding well. So, this is a scenario when we called all the troops out. We knew we were gonna go to war in the OR. We were fully prepared. We had everything lined up. Everybody had roles assigned so that we could move as quickly as possible, anticipating that she was going to need help. I think Dr. O'Daniel can agree that these sort of cases and scenarios, while sometimes they're interesting and impressive, they're not the standard. The normal times that we're treating abnormal hemorrhage or abnormal postpartum bleeding in an atonic uterus or hemorrhage, it's typically people that you weren't necessarily writing on the chalkboard that we're going to have a problem. Yeah, absolutely. Like, we're not expecting the scenario. I mean, personally, I expect every pregnant person to bleed and cause problems, but that's just because of what we do. But most of the time, it isn't somebody with a ton of risk factors or a huge history or someone that you're really concerned about. But you have an atonic uterus and you have abnormal bleeding, and you move forward to treat it. So I'll move on and let you share your case with us as well.
Of course. I am going to talk about my clinical case with the JADA system in a repeat C-section. And just like Dr. LaFleur mentioned, this is my personal case and my experience with this. So that just as a disclaimer. She's not wrong. I think these cases are great to talk about because they are ones that you'd expected and we were prepared. But the simulation and educating, refreshing is really what keeps us on our toes when these things happen unexpectedly for the patients that you were not intending for them to have bleeding. So this patient also was a little bit of extra clinical fun because she presented to me while I was on as an OB hospitalist. So she was not my patient, but I participated in her care because I was on at the hospital that day. And she presented as a 32-year-old G10P9009 at 37 weeks and 3 days. She had had a C-section that was scheduled for 39 weeks, but came and presented in labor. Her history was significant for 9 previous pregnancies, 3 of which were successful vaginal deliveries, then had a C-section, had 3 successful VBACs, and then ended up with another 2 C-sections after those successful VBACs. I'm not sure exactly what the indication was for that. She did have high risk for postpartum hemorrhage due to her grand multiparity. So we were prepared when she presented. She came in active labor and was 5 centimeters dilated, and was consented to proceed with a repeat C-section. And that's what she desired as well. So she underwent counseling consent for her repeat C-section and had a spinal anesthesia placed without any difficulty. And her C-section itself was really uncomplicated because we anticipated that she might have a postpartum hemorrhage. We actually had our postpartum hemorrhage cart just right outside of of our OR. At that time, we had a different building that we're in right now. So we had hemorrhage carts that were kind of placed throughout the labor and delivery unit. So we removed one of those and brought them to the OR in anticipation that she may bleed, as well as any of our uterotonic medicines as well. So she had uncomplicated C-section that had an 862 milliliter blood loss, and she did really well in the OR. She did have IV Pitocin that was infused per protocol in her surgery, so essentially immediately after the baby was delivered. And then recovered, just for a few minutes as we cleaned her up, and then transferred her to her postpartum room, which was her recovery room at that time. And when the nurse was assessing her for a fundal massage and assessing lochia, she noted that the patient's fundus was above 2, and her uterus was atonic, and as she began to massage, she got about 561 cc's of blood and clots that she quantified. So she asked for the primary OB to come into the room. He was actually just finishing up charting, and as he began to assess and knew that he might need an extra pair of hands, I was called in and brought in the hemorrhage cart that was sitting outside her door. So she had received multiple uterotonics when I walked into the recovery room, and she also had antifibrinolytic that was in her IV and infusing at that time as well. So after that decision was made to place the JADA, her quantitative blood loss at that time, inclusive of her operating QBL, was 1,423 milliliters of blood at the time of placement, and we immediately saw control of her bleeding. So I was able to feel on her abdominal exam that her fundus was firming up. If you are able to feel that, that's a great confirmation that the device is working. The other thing that you have access to, if you have one at your facility, is to be able to look with an ultrasound. This device is sonoluscent, so you can actually watch that work. It's really kind of cool if you are a geek like myself and really like to watch those types of things. I like to do that just for learning purposes, but if you can't feel, that would work fine. The other thing is that you can see the blood immediately come through that tubing. And so we were able to see, not only feel the fundus, but see that blood, and we could feel that contraction. So she had another 145 cc's of blood that was collected through that tubing and into the canister once it was placed. And then at that time, we maintained vacuum suction for a total of 2 hours. So this case itself was occurred probably about 3-4 months ago. And I would say it took us a little bit of time after implementing the use of this device in my facility to feel very comfortable with how fast the device is working, and also the time minimum that you need to use the device. Previously, having used a tamponade device where we were leaving that in for 12 to 24 hours, my facility is very evidence-based, but we're all also very anecdotally driven about what we see. And so we had to start to feel really comfortable with the fact that it's worked fast and that the minimum amount of time was less. And so we, over time, have gotten much more used to leaving this device in for its minimum amount versus trying to leave it in for 4 to 6 hours. So she had her vacuum discontinued after 2 hours. Just like Dr. LaFleur said, we leave that taped to her leg. So we discontinued the vacuum and we deflated her cervical seal. And we left that in for 30 minutes. So she had a total of 2.5 hours, and she did not have any reoccurrence of bleeding. So she had a QBL of 1,568 cc's in totality of her postpartum hemorrhage. So after that, I think just to kind of pull this full circle, we want to look at her postpartum care, and her hemoglobin was stable postoperatively. So we anticipated that she might bleed. She did not require any blood products during this postpartum recovery time. She had an uncomplicated postpartum course, and she was discharged from post-op day 2. So, I think that we all knew her grand multiparity increased her risk for postpartum hemorrhage. We really, all of us, myself, my nurses, that OB doc, that was her primary doc, we all anticipated that this event may occur. We were prepared. We had previously simulated. Everybody knew how to put the device together, where it was. If I asked for it, everybody knew what it was. We acted swiftly, and I really do feel like JADA was crucial in how efficiently and effective that we resolved this event. But I just want to reiterate that it's so nice to have that same familiarity, regardless of whether or not you're anticipating, because as soon as I say that I need a JADA in my facility, they all know where to get it, how to assemble it, and how to work through that with me. So I'm super grateful for the team that improves with simulation.